Hello everyone, and welcome back to the channel. Today we're talking about non-alcoholic fatty liver disease, a silent epidemic that remains unnoticed most of the time. So without further ado, let's get started. Non-alcoholic fatty liver disease isn't a single entity. It's a spectrum of liver disease characterized by the accumulation of triglycerides, or fat, in hepatocytes. We define it as hepatic steatosis affecting more than 5% of hepatocytes in the absence of significant alcohol consumption and other secondary causes. The spectrum breaks down into two key stages. The first is non-alcoholic fatty liver, the more benign form, where you have simple steatosis but little to no inflammation or hepatocyte injury. The second stage is non-alcoholic steatohepatitis, the progressive and more serious form. Here, in addition to steatosis, we see hepatocellular ballooning and lobular inflammation. This is the stage that can lead to significant fibrosis and ultimately cirrhosis. It is absolutely essential to understand why this is happening. While we now think of non-alcoholic fatty liver disease as a multi-hit process, the classic two-mechanism hypothesis provides a great framework. The first mechanism is insulin resistance. This is the foundational problem, in most cases associated with metabolic syndrome. Now, pay close attention to what I'm going to say next. Essentially, metabolic syndrome is the combination of high blood pressure, obesity, type 2 diabetes, and dyslipidemia. Therefore, insulin resistance, particularly driven by the presence of metabolic syndrome, especially the type 2 diabetes, leads to increased free fatty acid delivery from the adipose tissue. Then, the liver increases the lipogenesis process, converting these free fatty acids into triglycerides. These triglycerides will eventually be deposited as fat into the liver parenchyma, causing hepatic steatosis. In addition to that, the liver packages free fatty acids into very low density lipoprotein, or VLDL, and the overproduction of these particles leads to an increase in other bad lipoproteins like LDL, which is a key factor in the development of one important part of metabolic syndrome, dyslipidemia. It is basically a vicious cycle. Now you can understand why, when we see a patient with altered lipid panel, they often have fatty liver disease. The second hit is oxidative stress and inflammation. Oxidative stress occurs when there is an imbalance between the production of reactive oxygen species, which are often referred as the bad guys in our body, and the body's ability to neutralize them with antioxidants. In the context of fatty liver disease, this imbalance is exacerbated by the accumulation of fat in the liver. On the other hand, inflammation is the body's natural response to injury. In fatty liver disease, it is a key factor that distinguishes simple steatosis from the more dangerous NASH. The ongoing inflammation and oxidative stress lead to characteristic changes in the liver, including hepatocyte ballooning, swelling of liver cells, and increased rates of apoptosis, programmed cell death. Chronic inflammation and oxidative stress will cause hepatocyte injury, fibrosis, and eventually cirrhosis. A vast majority of patients with non-alcoholic fatty liver disease are asymptomatic, which is why it's often called a silent killer. However, as the disease progresses to NASH and cirrhosis, symptoms can emerge. For instance, in the early stages, you might see fatigue and a vague right upper quadrant abdominal discomfort. With advanced disease and cirrhosis, you'll see the classic signs of hepatic decompensation. This includes jaundice due to hyperbilirubinemia, ascites from portal hypertension, peripheral edema due to the low level of albumin in the blood, and spider angiomas. Hepatic encephalopathy is another classic sign, as the liver's failure to detoxify ammonia leads to neurological symptoms. It is absolutely crucial to understand the risk factors, so pay attention to what's coming next. The first risk factor is obesity, especially central obesity often seen on the anterior abdominal wall. The second one is type 2 diabetes. As we discussed a couple of minutes ago, insulin resistance is the central driver. Another key risk factor is dyslipidemia, with high triglycerides, high LDL cholesterol, and low HDL cholesterol. This lipid panel often comes associated with high blood pressure, which further promotes the atherogenic status. Personal habits like a poor diet, no physical activity, or smoking can increase the chances of developing fatty liver disease. When it comes to the diagnosis of non-alcoholic fatty liver disease, let's start with initial lab work. Look for incidentally elevated liver enzymes, particularly alanine aminotransferase and aspartate aminotransferase. Often, the AST-ALT ratio is less than 1 in non-alcoholic fatty liver disease, which can help differentiate it from alcoholic liver disease. From clinical practice, we often see patients with alcoholic liver disease and gamma-glutamyl transferase higher than normal. So this will be a major indicator of what we're looking at. Also, assess for metabolic syndrome markers such as fasting glucose, lipid panel, and glycated hemoglobin. Moving on to imaging, a key tool is ultrasound. This is often the first line and most widely used tool as it can identify hepatic steatosis. When we describe a fatty liver, we often refer to it as high echogenic structure. This means the liver is brighter than normal. We compare the echogenicity of the kidney and the liver, which usually have to be similar. We find that the liver is brighter than the kidney, which indicates hepatic steatosis. Next, we have elastography, or the fibroscan, which is a non-invasive test that measures liver stiffness, which correlates with the degree of fibrosis. It's excellent for screening and monitoring disease progression, especially in patients at risk of developing cirrhosis. The gold standard remains the liver biopsy. This is the definitive diagnostic tool and is the only way to accurately stage the disease and assess the degree of fibrosis and inflammation, but it is usually not required. The good news is that lifestyle modification is the cornerstone of non-alcoholic fatty liver disease management. The most effective intervention is weight loss. Even a modest weight loss of 5 to 7% can improve steatosis. A loss of 7 to 10% can lead to the resolution of NASH and a regression of fibrosis. Diet and exercise are also essential, with a balanced diet and regular moderate intensity aerobic exercise. As far as pharmacotherapy goes, there are currently no FDA-approved medications specifically for non-alcoholic fatty liver disease, but several are used off-label or are in clinical trials. These include pioglitazone, a thiazolidinedione that improves insulin sensitivity, and GLP-1 receptor agonists, which promote weight loss and have shown positive effects on liver histology. Vitamin E, as an antioxidant, can also improve liver enzymes and histology in non-diabetic NASH patients. With that being said, here we wrap things up. If you found this information helpful, please give this video a like, subscribe to the channel for more health insights, and let me know in the comments what other topics you'd like me to cover next. Thanks for watching, and we'll see you in the next one.